Thank you, Mr. Chairman. Thank you, Secretary, for being here. This committee has a long tradition of bipartisanship, and I know, Secretary, you and I have had a couple of disagreements in private and in public, so I want to kind of see whether we can find some common ground in fighting the coronavirus. The President's budget cuts the Infectious Disease Rapid Response Reserve Fund, the Public Health Preparedness and Response Fund, Hospital Preparedness Program, and the Epidemiology and Laboratory Capacity Program. So given everything that's happened over the last 50 days, I want to give you an opportunity, and given the context here, which is last night you proposed a $2.5 billion supplemental, do you want to rescind those cuts to the base budget of your agencies that deal with this problem?
Well, it's a good question, Senator. As I mentioned to Chairman Blunt, this is a request focused on 2020 money, so money to be spent.
Hold on. Well, no, hold on. I'm not asking you about the SUP. I'm asking you about the President's budget, which cuts all those programs which I described. And the question is a simple one, because I have a couple of other questions I'd like to get to. Will you rescind those cuts? Will you ask us to restore those programs, or will you not?
So, as I said to Chairman Blunt, we will work with you over the coming months as we learn more about this disease on whether to modify the 2021 appropriation requests in light of that. We do increase by $135 million CDC's budget around preparedness, emergency response, infectious disease, and global health security.
I'm not going to get too much into the weeds there, but I will just offer that actually is a shell game. There are 4 key programs that deal with this problem. They are being cut. The CDC overall is being cut by 9%, and so you may have increased a line item or two, but that's a talking point. That is not the fact of the matter. And this committee will very likely reject these cuts. But it is absurd to me that you're proposing cuts at the same time that you're proposing a supplemental on the same topic. So moving on, how many masks do we need in our strategic stockpile, and how much will that cost?
So we would need to determine through procurement what the cost would be of additional masks. I know that this morning in the briefing there was a reference to possibly as many as 300 million masks needed in the U.S. for healthcare workers. We want to define that better through procurement criteria. We have to, frankly, establish supply here in the United States, ability to manufacture, as well as to find sourcing of active ingredients such as the filtration materials, even the nickel and copper nose joints that go on the N95 masks. So if we get the money, we can actually make that market and get capacity built here in the U.S.
Understood.
We want to work with you on.
But for the $2.5 billion, like the masks in the strategic stockpile, the test kit, all of your 5 lines of effort, it seems to me you don't quite know how much each line of effort is going to cost. Is that accurate?
We would have to do procurements to find out exactly what our per unit cost would be on the masks, because again, we'd be scaling up domestic production that doesn't fully exist right now. So one doesn't know until one actually procures those.
So how do you get to 2.5 not knowing how to compile? You have 5 lines of effort. You don't know how much, the first one I'm asking about, you say you got to go through procurement, you got to build a market. I understand all that. So then how do you get to 2.5 with any degree of specificity or reliability? Is $2.5 billion sort of pulled out of a hat?
No, not at all. The $2.5 billion actually
but one of the major cost items, you don't know how much it's going to cost.
You don't know the precise per unit cost, but in the range of the hundreds of millions of dollars we're dealing with, that clearly would be sufficient. I think right now acquisition cost for N95 masks tends to be under $1. So that gives you a rough approximation, but we have to scale up domestic production.
So do you have back of the envelope numbers that you haven't yet provided to the committee? Because it sounds like you have, well, but it sounds like you have ballpark numbers. And I got told by a staff person that the SUP, now I haven't gone through it with a fine-tooth comb yet, but I have been told that this is the least detailed supplemental that they've ever seen.
Well,
so should we just consider this a marker? And you'll get us the details later?
Not in the least. There's a letter that went up last night which has the basic numbers in it. And as I've told both the chairman and the vice chairwoman, we will work with your staffs to get you the details behind that. There is detail behind that. It's just last night you got the initial letter.
Okay, final question on test kits. They were deployed into a bunch of locations. They didn't function properly. Why in the world do we have test kits? Do we have tests that operate in Atlanta but can't be, and and the country of Japan has test kits that are reliable. Other places, first of all, other states, but also other countries have operating test kits. And given all of the preparedness work that you say you've been doing and all of the extraordinary work of all of our agencies, why can't we deploy test kits that function? And why does it have to be mid-March before states and especially ports of entry have functioning test kits?
So as I mentioned before, the CDC test was developed with historic speed. It has 3 reagent phases on it. The third one, it's unclear whether it's actually necessary, but what we do whenever it deploys out into the field or at CDC, one has to do the quality control and validate those results. That validation failed at the 3rd stage, not for false positive or false negative, but simply for inconclusive results against control in one of the 92 reagent slots.
Thank you.
We are now
I'm sorry,
working on streamlining that process with FDA, so we hope to get those revised ones out very quickly.
Thank you.